Locked out of sleep, the relationship between incarceration and insomnia. Studies show that incarceration results in an elevated risk of insomnia and overall poor sleep. Insomnia is a difficulty initiating or maintaining sleep, which results in distress or impairment in functioning and is present for at least 3 times a week for 3 months. The prevalence of insomnia in the United States and Europe is believed to be about 6 to 10% in the general population. However, according to Shepard and Hogan's literature review of 12 studies on the topic, prevalence rates for insomnia within prisons ranges from 26 to 73%, with poor sleep quality rates ranging from 43 to 88%. These findings are variable due to the methods used in each study, but in the main, inadequate sleep amongst prisoners is considerably higher than in the general population. Contributing factors to these sleep issues are found at the individual, psychological, and environmental or institutional levels, with multiple feedback loops. This means that, in addition to these factors contributing to sleep issues also contribute to said factors. Individual level factors include incarcerated people having higher rates of mood disorders and chronic pain. Both these pre-existing vulnerabilities show feedback loops, where, for instance, chronic pain may contribute to insomnia, and insomnia in turn may worsen chronic pain. The same goes for psychiatric diagnoses like depression and PTSD, which are bidirectionally related to insomnia and poor sleep. Psychological factors include internal cognitive and emotional processes like feelings of guilt, rumination, anxiety, and isolation. In addition, many prisoners experience trauma due to the quality of health care received in prison, such as dismissal of their health concerns or lack of resources, which in turn creates serious fear related to their health. They especially highlight a fear of dying in their sleep, which seriously impacts their sleep quality and quantity. Once again, creating a feedback loop, these emotional processes lead to sleep deprivation, and in turn, sleep deprivation can lead to emotional dysregulation, which amplifies psychological distress. Environmental and institutional factors, of course, include the physical environment, like constant noise, inadequate bedding, or extreme temperatures, but also restrictive policies, like certain jails' policy to keep lights on until at least 11 p.m., administer medications at 2:30 a.m., and turn lights back on at 4 a.m. for breakfast, barely allowing for any sleep. Restrictive policies also include a lack of access to treatment for sleep disorders. In Ilun and al.'s study, participants mentioned that parasomnias such as nightmare disorder, sleep paralysis, sleepwalking, and night terrors impacted their sleep, but that they were unable to get treatment until after release. Many mentioned feeling like the medical staff believed their requests for help were drug-seeking behaviors. Several court decisions in the U.S. even cast doubt on whether insomnia alone constitutes a serious medical need in prison. There are even cases where medication prescription to treat insomnia may be discouraged or even prohibited because of concerns about incarcerated individuals sleeping away their sentences. The social environment in prison also impacts sleep. Many incarcerated individuals mention fearing assault, which contributes to sleep problems during and after incarceration. They describe being light sleepers who can wake up at any sound, which can indicate not getting to deeper sleep stages necessary for cell recovery, memory consolidation, and overall good health. Exposure to violence, for example witnessing death by suicide, which was mentioned by participants, may also contribute to sleep problems like insomnia, nightmares, and night terrors, and may interfere with achieving the appropriate duration for each sleep stage, especially rapid eye movement sleep. The feedback loop here is that incarcerated people reporting poor sleep are more likely to report higher levels of aggression and lower impulse control. This can undermine rule compliance, resulting in punishment, for example, solitary confinement, and therefore more adverse environmental conditions, which further disrupt sleep. In turn, it also creates a positive feedback loop in which sleep deprivation due to fear of violence propagates more violence by heightening sensitivity to even minor events. Overall, sleep in prisons is a multi-level and multi-directional issue. These levels and directions can be considered to treat insomnia and other sleep problems at multiple points in the feedback loops. This is essential because sleep is a significant factor in health disparities, both for incarcerated individuals, but also for minoritized populations who are disproportionately impacted by incarceration.